Welcome to the deep dive. We are jumping straight in today with a high-speed, high-yield journey through the material science of surgical implants.
Exactly.
This is really for you, the plastic surgery resident getting ready for boards. We want to distill the absolute must-know principles and facts.
Right. And it's not just about memorizing lists. It's about connecting, the chemistry of a material to what actually happens when you put it in a patient. We've got a lot to cover, so let's get right to it.
Okay, so let's start with the ideal, the perfect implant. I mean, it's a bit of a unicorn, but what are the fundamental criteria we're aiming for? There are 9 of them, and it's so rare to hit them all.
It's the ultimate design challenge. The easiest way to think about them is in 3 buckets. First, the biological side.
Okay.
The material absolutely has to be non-allergenic, non-carcinogenic, and it can't be a place for microorganisms to set up shop.
Right, no biofilm. What's the second bucket?
That's the mechanical properties. It needs to be strong, resistant to fatigue, but also easy to shape. And critically, it has to resist absorption, corrosion, and deformation over time.
And the last piece, that's the practical, clinical stuff.
That's it. It has to be reliably sterilizable, ideally radiolucent, so you can see what's happening on an X-ray.
Which is a huge deal.
Huge. And of course, it needs to be inexpensive and readily available. That's the 9-point standard. Everything we talk about today gets measured against that.
Perfect. So with that standard in mind, what are the main reasons we'd use an implant, and what are the 4 big red flags, the reasons to stop and reconsider?
Indications are pretty straightforward. Stabilizing fractures and reconstruction or augmentation of soft tissue and bone. But the contraindications are what you really need to memorize for your exams.
Okay.
There are 4 key relative contraindications. 1, implanting into a radiotherapy field. 2, poor surrounding blood supply.
Bad news for any implant.
Always. 3 is tenuous or fragile soft tissue coverage. And 4, of course, is active infection. If you see any of those, you have to be extremely cautious.
That sets the stage beautifully. Let's move into our first major category, liquid and injectable implants. We have to start with silicone. The terminology alone trips people up. For the boards, what's the difference between silicone, silica, and silicone?
This is a classic question.
Yeah.
Okay, so silicon, that's the element on the periodic table.
Right.
Silica is silicon dioxide, think sand, quartz. But silicone, the medical material, that's a polymer, polydimethylsiloxane.
And how do we get so many different consistencies from that one polymer, from a liquid gel to a solid implant?
It's all about the polymer chains. If you have short chains, you get a viscous liquid.
Okay.
You make those chains longer, you get that cohesive gel we see in modern breast implants. And then if you cross-link those long chains, you get solid, more rigid silicone.
The body handles silicone pretty well, but the reaction isn't zero. What's the standard biological response, and is there a specific risk in, say, hand surgery?
Right, so it's chemically inert, but the body still sees it as a foreign object. You get a mild foreign body reaction, and the result is always the formation of a fibrous capsule around it.
That's the expected outcome.
Yes. But when you use silicone prostheses for joint arthroplasty, the key risk you need to know is chronic synovitis. That's a specific one to remember.
Okay, you mentioned encapsulation. That makes me think of bioplastic. Is that just a different type of silicone?
That's a great question. It's actually a bit more clever. Bioplastic is made of tiny, textured silicone rubber microparticles, and they're suspended in a hydrogel carrier.
So the body reacts differently.
It does. Instead of forming one big capsule around a single implant, the body encapsulates each individual microparticle with fibrous tissue. The theory is that this promotes better integration.
Interesting. Now let's shift to temporary fillers. We don't really use the old animal-based collagens anymore. Why did they fall out of fashion?
It was purely a practical issue. They required mandatory allergy testing before you could inject them.
Which added a lot of time and complexity.
A huge amount. It just wasn't practical once safer, easier alternatives came along.
And those alternatives are mainly hyaluronic acid and calcium hydroxyapatite. Let's focus on the HA fillers like Restylane and Juvederm. What's their main advantage?
Well, they're made synthetically, so the risk of an allergic reaction is incredibly low. They're also really versatile for fine lines, wrinkles, lip definition. But the key technical point for exams is the absorption rate.
How long do they last?
On average, you lose about 20 to 50% of the volume within 6 months. They are not permanent.
Got it. Okay, that covers liquids. Let's switch gears completely to the solid implants, metals. They're foundational, but they have major trade-offs. Let's break down the big 3. Stainless steel, Vitalium, and titanium.
All right. Starting with stainless steel, it's an alloy of iron, chromium, and nickel. Clinically, its biggest downside is a pretty high incidence of corrosion.
And you can get galvanic currents, right, if you
Yeah.
mix components.
Exactly. That's a serious risk.
Okay, so what about Vitalium? How does it compare on strength?
Vitalium is an alloy of chromium, cobalt, and molybdenum. It's much more corrosion resistant than stainless steel, and here's a key fact. It has a higher tensile strength than both stainless steel and titanium.
That's a great board tip. So then titanium, it's everywhere now in craniofacial. Why?
Titanium is an element, though it's often alloyed with aluminum and vanadium for plates and screws. Its strength is similar to Vitalium, but its big advantages are malleability and incredible corrosion resistance.
And what about imaging?
That's the game changer. Titanium produces way less artifact on MRI and CT scans. For anyone doing post-op imaging after a complex facial fracture, that clarity is essential. It's basically the gold standard for osseointegration.
Makes sense. Before we leave metals, where does actual gold fit in? It's corrosion resistant, but not very strong.
It has a very niche, very specific application. As an upper eyelid weight in facial palsy cases. Helps with eyelid closure to protect the cornea.
Okay, that clarifies the metals. Now for the biggest and most controversial category, polymers. I have to start with polyurethane. There's a paradox here. It was used in breast implants because it causes an intense foreign body reaction. Why?
It's all about the outcome of that reaction. Yes, polyurethane causes an intense reaction, which leads to major tissue adhesion.
Right.
But that very adhesion and texture resulted in a much, much lower rate of capsular contracture compared to the smooth implants of the day. So surgeons made a trade-off.
And that leads us to the big controversy from the 90s, the cancer scare over its breakdown product, 2,1,4-toluene-diamine, or TDA. What did the follow-up studies actually find?
This is a classic board question. The initial fear was real, but later analysis showed that the TDA found in patients' urine was actually a lab artifact.
An artifact. How?
The testing process, the assay, required boiling the sample in strong acid. That aggressive step was actually breaking down harmless polyurethane oligomers into TDA. So it looked like it was in the patient, but it wasn't. It was created in the test tube.
That is a critical distinction. Okay, moving on to fluorocarbons. What makes something like Teflon or PTFE so stable in the body?
It's the carbon-chlorine bond. It is one of the strongest chemical bonds there is, so it's incredibly resistant to being broken down by human enzymes.
But we have seen some failures, like Proplast 2. They were pulled from the market. What went wrong there?
Proplast 2 weren't pure PTFE. They were composites mixed with carbon or aluminum oxide. And those composites had really high rates of complications, especially infection and extrusion. It was a disaster in the TMJ.
So how is Gore-Tex different? It's also PTFE, but it works so well for things like vascular grafts.
Gore-Tex is an expanded PTFE sheet. That expansion process creates a porous microstructure. It's still soft and strong, but that porosity allows for controlled tissue ingrowth, which stabilizes the implant.
Ah, so the ingrowth anchors it.
Yeah.
Let's talk about polyethylene. There are 3 grades. What are they, and how does the high-density version, MedPore, work so well for the facial skeleton?
The 3 grades are low density, high density, and ultra-high molecular weight. MedPore is the high-density porous version. It causes very little foreign body reaction, and just like with Gore-Tex, that porous structure allows soft tissue to grow right into it, locking it in place.
And the ultra-high molecular weight grade.
That one's reserved almost exclusively for heavy-duty, load-bearing orthopedic implants. Think hip replacements.
Got it. Let's do a few quick-fire polymers. The best material for arterial prostheses.
That would be Dacron or PT polyethylene terephthalate.
And the biodegradable polyesters, like polyglycolic acid, what's their breakdown mechanism?
Simple hydrolysis. Water in the body slowly breaks them down over a few months. That's why they're perfect for miniplates in pediatric craniofacial cases that need to disappear as the child grows.
Makes sense. And polypropylene, like in Marlix mesh?
It's very similar to polyethylene, but has a methyl group that gives it incredibly high tensile strength, while the mesh form still allows for that crucial tissue ingrowth.
Okay, now for a critical one. Polymethyl methacrylate, PMMA, bone cement. What is the #1 absolute safety issue you have to know when you're using it for, say, calvarial remodeling?
It's an exothermic reaction.
It gets hot.
Extremely hot. The polymerization process can generate temperatures up to 70 degrees Celsius. So you must cool it with saline or ice water as it sets, or you will cause a thermal injury to the patient's scalp or even the brain.
That's why you always see that bowl of ice water in the OR. What about the permanent injectable fillers that use PMMA, like Articol?
They use tiny PMMA microspheres suspended in bovine collagen.
Hmm.
The body absorbs the collagen carrier, but the PMMA spheres are permanent. They get encapsulated and provide that long-lasting volume.
And last one in this group, cyanoacrylate, superglue. How does that work as a tissue adhesive?
It also has an exothermic polymerization, but on a much smaller scale. It sets almost instantly on contact with water. We use it for closing simple skin edges, securing skin grafts. It's especially great for simple cuts in kids to avoid sutures.
All right, on to our final classification, ceramics. These are all calcium compounds. What are the three main types?
The three you need to know are calcium sulfate, calcium carbonate, and calcium phosphate.
And what's the key property of calcium sulfate, which is basically plaster of Paris?
A key thing is that it dissolves in body fluids faster than bone can grow into it. It resorbs very, very quickly. Calcium carbonate, on the other hand, comes from coral and is hydrothermally converted to hydroxyapatite for clinical use.
Okay, and calcium phosphate is the big one. It's the main inorganic part of natural bone. How do we differentiate the two main forms based on resorption?
This is a critical distinction. You have tricalcium phosphate, which is remodeled and completely resorbed by the body in an osteogenic environment.
It disappears.
It disappears. In contrast, apatite, like pure hydroxyapatite, is generally considered non-absorbable. It remodels very, very slowly, if at all. Now, there are some carbonated apatites like Norian that do resorb, but you have to know that core difference between tricalcium and pure apatite.
So where do we actually use these calcium phosphates in our field?
All over the place. Filling bone defects after removing a tumor or a cyst, augmenting autologous bone graft, backfilling an iliac crest donor site.
And in craniofacial remodeling, you mentioned distinguishing between inlay and onlay.
Right. For the boards, know that inlay means replacing the full thickness of the skull, whereas onlay is just augmenting part of the outer table of the skull.
We mentioned Radiesse earlier. It's made of calcium hydroxyapatite. How does that affect how we see it on follow-up imaging?
Because it's calcium hydroxyapatite, it's not very soluble and can persist for a long time. But the key clinical point is that on an X-ray, Radiesse is intensely radiopaque. It shows up as bright white. We've covered a huge amount of ground here, from liquids and metals to all these complex polymers. If you take away just one thing, it should be that link between the material's chemical structure, the cross-linking, the alloying, that carbon-fluorine bond, and its ultimate fate in the body. Is it going to dissolve, get walled off, or slowly remodel?
Absolutely. The chemistry really does predict the biology. And as you're reviewing your notes today, here's a final thought to mull over. Considering all this variability in resorption rates and implant properties, what's the key factor that makes a surgeon choose a bone filler that's distinctly radiopaque versus one that's completely radiolucent for a specific craniofacial defect? Think about whether you need to see the filler on post-op imaging or if you need to see the new bone growing through it. Mull that over until our next deep dive.